Hello, and thank you for inviting me to speak on hypertensive emergencies and urgencies, or as I prefer to term it, acute severe hypertension. So let's begin with a case. Here's a 16-year-old obese boy who presents to an outside physician complaining of headache and blurry vision. Blood pressure was measured at 170/120. Repeat blood pressures were similar. He was sent to the local emergency department for evaluation, and there he was found to have bilateral papilledema and retinal hemorrhages on examination. He also was found to have slightly elevated BUN and creatinine. On imaging, he had cardiac enlargement and pulmonary edema, and he was admitted to the pediatric intensive care unit for management. So that sets the stage for what we'll talk about in the rest of this time. It raises some questions which I hope I will answer for you. What blood pressure level actually represents severe hypertension in a 16-year-old boy? What are the common causes and presentations? And what is the best approach to management? So, acute severe hypertension. This constitutes blood pressures associated with target organ effects, and these are considered severe. They are typically well above the 95th percentile or even above stage 2 hypertension. And clearly it is a concern if the patient has symptoms or involvement of target organs. Traditionally, acute severe hypertension has been divided into two categories: hypertensive emergencies and urgencies. But it's an artificial distinction. It's actually more of a spectrum, and you need to use clinical judgment when thinking about these patients and their management. But just for purposes of this discussion, what do we usually think of as hypertensive emergencies? So these are acute severe blood pressure elevation that produce severe, often life-threatening symptoms, typically involving the central nervous system or the heart. There are various syndromes that are associated with hypertensive emergency, including hypertensive encephalopathy, congestive heart failure with pulmonary edema, like the boy that I presented, acute kidney injury, retinopathy, papilledema, and cortical blindness. On the other hand, a hypertensive urgency is defined as a severe symptomatic blood pressure elevation not associated with life-threatening symptoms. There may be some features of accelerated hypertension, such as retinopathy without papilledema. And typically, hypertension in a postoperative patient or after kidney transplant is considered to be a hypertensive urgency. It is not the same as asymptomatic, poorly controlled severe blood pressure in a known hypertensive patient. We're not going to be talking about that today. But it's important to recognize this situation because it can progress to hypertensive emergency if the blood pressure is not brought under control. So if we look at the blood pressure categories in the 2017 American Academy of Pediatrics Pediatric Hypertension Guideline, the highest category is stage 2 hypertension, which is anything at or above 140/90, no matter how old the child is. But actually, typically when you see patients with hypertensive crisis, the blood pressure is much higher than that. So according to the guideline, stage 2 hypertension is greater than 140/90. But the guideline also talks about what levels of blood pressure should you be concerned about acute symptoms. And so there, the recommendation is 30 millimeters or more above the 95th percentile. So his blood pressure of 170 over 120 is certainly in the range that could cause acute target organ damage. And so what are the causes of this problem in children? So in this table, taken from a review that Chaltoulis and I wrote several years ago, you can see that the primary causes start with kidney diseases like glomerulonephritis, end-stage kidney disease, and then things like various malignancies, vascular complications, particularly renal artery stenosis, and then some other miscellaneous ones. And you can think about it in different age categories as well. So in this table, we've sort of taken the different causes of acute severe hypertension and divide them up by age. So for example, in infancy, renovascular disease or a congenital kidney abnormality would be most common, whereas in teenagers, primary hypertension or some form of parenchymal kidney disease is probably most common. And indeed, when you look at case series of children with severe hypertension, that's what you see. So here's a case series from Taiwan, published about 10 years ago, that looked at first attack hypertensive crisis presenting to an emergency department. So it was 55 children who presented with hypertensive crisis. They said 9 of them had hypertensive emergency and 46 with urgency. All of them had blood pressure levels stage 2 hypertension or higher, and it was much more common in older children than in younger children. And then this is some of the characteristics of their patients, and I'll walk you through this table. So they tended to have high BMI. You can see the BMI Z-score was as high as 3 in the teenage group here in the right-hand column. They had quite high blood pressures. You can see even the infants had very high blood pressures, but all of them had blood pressures well above stage 2 hypertension. And you can see the Z-scores for the systolic and diastolic blood pressure. So again, quite high blood pressures. And when you looked at what were the causes of severe hypertension in this group, well, the most common was primary hypertension, which actually isn't surprising, knowing that teenagers constituted the largest group of their patients. But right after that were kidney disorders and endocrine problems, as you can see. Now, at Great Ormond Street Hospital, they have quite an experience with severe hypertension. And here is a table of how their patients have presented. So interestingly, incidental was the largest number. In other words, these are children that have severe blood pressure elevation found during workup for something else or because they had their blood pressure taken for some other reason. But right after that, you have patients who have cardiac symptoms, patients with headache, hypertensive encephalopathy, and so on. And then here is another case series that I think is interesting to look at. This was actually a clinical trial of the efficacy of, or retrospective examination of the efficacy of labetalol. But there's some interesting points amongst their patient population. So if we make this a little bit larger, you can see, again, there was quite high blood pressures, 167 over 116, 174 over 120. You can see there was actually a male predominance here. And then the other interesting thing is that what they saw were headache, nausea, and vomiting were the most common symptoms. And when you looked at other things, they had many patients with kidney involvement and cardiac involvement. And right here at the bottom, kidney disease was the most common etiology, accounting for about 60% of their cases. And then finally, when you look at that Taiwan series that I presented, you can see that they had end organ damage in about 15%, but their most common symptoms tended to be more central nervous system, so dizziness, nausea, vomiting, and headache. All right, well, why do these symptoms develop, and particularly why are so many of these children presenting with neurologic symptoms? So that gets us into a discussion of hypertensive encephalopathy. So as you know, cerebral autoregulation usually maintains a steady perfusion pressure to the brain, even across a wide range of systemic mean arterial pressure. But if blood pressure exceeds a critical level, then the vessels dilate and you get excessive blood flow with resultant cerebral edema. And you can see that here, where normally there is a balance between vasoconstriction and vasodilatation, maintaining a constant cerebral blood flow. But if you get to a very high systemic mean arterial pressure, there's autoregulation failure, and you get cerebral hyperperfusion. And that then leads to many of these symptoms. In patients with chronic hypertension, that critical level can be higher, as we'll talk about in a bit. And then if you think about other organ systems like the kidney, for example, there are autoregulatory mechanisms there as well, which maintain pressure or normal perfusion, but which can be exceeded, leading to the acute kidney injury in patients with severe hypertension. Now, what about this posterior reversible encephalopathy syndrome or hypertensive encephalopathy? Are they the same thing? Well, they're very related, and it's sort of hard to untangle it. So PRESS, as you know, is a term that's used to describe a combination of neurologic findings, including headache, altered consciousness, acute cortical blindness, even seizures and stroke. Severe hypertension is one of many different predisposing factors to PRESS. Others may be chemotherapy, for example, or calcineurin inhibitors. There are characteristic imaging findings, including vasogenic edema, particularly in the posterior distribution of the cerebral circulation, which is actually quite similar to what has been described as in classic hypertensive encephalopathy. The pathophysiology is complicated, and it may be related to endothelial dysfunction. It may be related to other things like the hyperperfusion from autoregulatory failure that I talked about. And in this cartoon, this cartoon illustrates the two sort of things that are going on in these patients, including, issues related to cerebrovascular autoregulation, issues related to endothelial dysfunction, cytokine release, and things like that, which then lead to some of the symptoms that these patients present with. And if you look at the imaging, well, classically, it has this posterior distribution. So this is an old paper with an MRI showing the classic posterior distribution of MRI changes, but not all PRESS is posterior. And in this pediatric series, you can see abnormalities in imaging, even in the frontal lobe and other parts of the brain as well. Okay, so let's move on to assessment and management. So when the patient, like the one I talked about, presents, it's important to do a focused history. Is there a history of hypertension that they already know about? kidney disease or heart disease. Then a focused physical examination, looking for the manifestations of target organ involvement, like retinal hemorrhages, congestive heart failure, neurologic abnormalities. And then laboratory and imaging evaluation, you're going to need to do kidney function tests, CBC, chest X-ray, and potentially echocardiogram and kidney ultrasound eventually as you're working up the patient. And then what about moving on to management? So first of all, we want to avoid rapid drops in blood pressure. And this is because, as I've already alluded to, cerebral autoregulation can be shifted. And so if you look at this modification of that diagram I showed you earlier, in patients who have chronic hypertension, this autoregulatory changes shift to the right the level of systemic blood pressure at which the brain is maintaining a normal perfusion pressure. So if you then drop the blood pressure too far, you will cause cerebral ischemia. And that's an important point to keep in mind in managing these patients, something you want to avoid. So the goal is a gradual return to normal blood pressure. And so basically what the recommendations are is 25% of the planned reduction over the first 8 hours. And then over the next 1 to 2 days, get down to a normal blood pressure around the 95th percentile. You need to monitor the patient closely, because if you drop the blood pressure too quickly, you may cause neurologic changes. So you're going to watch for that. And if that happens, you may need to slow the rate of blood pressure reduction. All right, so the question comes up, are we going to give intravenous agents or oral agents? So IV antihypertensives usually work fairly rapidly. When you give them by continuous infusion, they produce a more controlled fall in blood pressure than most oral agents, but you need to know what you're doing. You need to have the ability to give a continuous infusion, and you need to do continuous blood pressure monitoring. They are what is preferred in most urgent situations. Oral agents typically have too slow of an onset of an action to be effective, and sometimes the magnitude of blood pressure reduction can be unpredictable. And I don't have time in today in this talk to go into that, but many oral agents actually may drop the blood pressure too far or may last longer than you want. However, in less severe patients, they can be useful, or less severe hypertension, excuse me. So typically a continuous infusion is the appropriate treatment. And many times these patients are too ill for oral medications anyway, so you need to give something IV. And so this will typically require, placement of an arterial line for frequent blood pressure monitoring. If you don't have an arterial line, you can set up an oscillometric device to take blood pressures every 5 to 10 minutes, and that's an acceptable second choice. So when you look at the drugs that are available, these are the drugs that are available to be given by continuous infusion. I've highlighted in red the ones that are probably the most commonly used in most centers, labetalol and nicardipine. And then on here on the right are agents that can be given intravenously as bolus drugs. And again, probably in red, hydralazine and labetalol are the most commonly used, although there are many different ones, as you can see. For less severe hypertension, there are some oral drugs which can be used. And again, I've highlighted in red the ones that are probably most commonly used. At our institution, we use isradipine and clonidine, probably most often as oral agents for less severe hypertension. And then this is sort of the proposed algorithm for the initial management of these patients. If the patient has life-threatening symptoms on the left, you would sort of put them in that hypertensive emergency category. And then we recommend giving a bolus dose of something that's going to work immediately, like labetalol or hydralazine, and then get your infusion started after that. If they have minor symptoms and they're able, you would put them into that hypertensive urgency category. If they're able to tolerate oral medications, you would give them maybe isradipine or clonidine. If they're not able to tolerate oral medications, you would give them hydralazine or labetalol. Now, let's go back to our case. So remember, this was a 16-year-old who presented with severe hypertension. He had papilledema, retinal hemorrhages, evidence of acute kidney injury, evidence of congestive heart failure. So what happened to him? So he received a bolus dose of IV labetalol and then was placed on a nicardipine infusion. It brought his blood pressure down to 150/80, and his acute symptomatology resolved. Further workup showed a small left kidney, left renal artery occlusion, and this is how I came to be acquainted with this patient, because he was actually managed elsewhere but referred to our center for management of his renal artery stenosis, which we were able to treat successfully with angioplasty. So to summarize, the level of blood pressure, which we would categorize as acute severe hypertension that may produce hypertensive urgency or emergency, much higher than stage 2 hypertension in pediatric patients. The most important feature to think about are the symptoms, is the target organ involvement. There are many different causes, as we've talked about. Kidney disease is going to be the most common in pediatrics. And when you are managing these patients, you need a controlled approach to reducing their blood pressure. And typically, this would constitute an infusion of an intravenous antihypertensive agent. I thank you for your attention, and I look forward to your questions.